Yeah, welcome to Decoding CTO case 27. So today I'm bringing a case of right coronary artery CTO, which is my most hostile CTO I have done in my career. I'm Dr. A. Sharath, interventional cardiologist, Medicover Hospitals, Hyderabad. So my patient is 58-year-old male, old anterior MI, had a cardiogenic shock for which primary PCI with stent to LED was done. There was RCA CTO at that time, but not treated because of complexity. The patient had moderate LV dysfunction, which continued even subsequently, and normal sinus rhythm. But currently he came with exertional angina despite optimal medical therapy, and stress nuclear scan showed inducible ischemia in inferior wall territory and also it's a viable territory. CAG done, showed patent stent in LAD and right coronary artery CTO. So these are the comorbids. So this is an ECG showing no Q wave in infiltrates, and you can see inferior wall is quite normal in thickness and mobility, which says it is viable. This is a coronary angiogram. You can see stent is patent in LAD and RCA is filling from collaterals from LAD, and there are two kinds of collaterals. One is filling PDA, another is filling RV branch. So yeah, this is again same patent stent, and this is a septal collateral which is filling PDA, and these septal collaterals are filling RV branch. So this is a right coronary artery injection. You can see there is a total occlusion, but also bridging collaterals, Cori microchannel, which we don't know. It's very difficult to visualize when so many branches are coming around CTO. Yeah, this is left injection and right injection in the same view, just to understand the length of the lesion. So you can see definitely the lesion length looks more than 20 millimeter. Yeah, this is ANATOMICOGRAM of patient. So looks there is an entry point, but I'm not sure because of the multiple branching. Length is definitely more than 20 millimeter, and there is no obvious calcium visible here. And bend, yes, there is a bend across the CTO, and it's first time attempt lesion. So overall JCTO score is 2. And the plan of wiring here is basically proximal cap is clear, and you have a good distal vessel visible, but mostly in antegrade injections, not in retrograde injections. So in that scenario, we can try an antegrade wire-based approach. If not successful for any reason, then you can move on to retrograde, as he had good interventional collaterals. And the major challenges in this case is it's a proximal RCS CTO, and the guide support is going to be a big issue during procedure. Yeah, we can take an AL guide, and also we can take an anchor balloon from atrial branch if needed. And stent in the donor vessel is another challenge. So when you go retrograde, I think you have to do intravascular ultrasound after coming out of retrograde vessel to re-optimize LED stent. So this is what we have done. As a catheter is not sitting in right coronary artery, we just sent a microcatheter. We took a dual injection with antegradely microcatheter and retrogradely directly through the guide. We can see there is a CTO here with multiple branches, which definitely going to confuse your wiring. So anyway, we gave a microcatheter injection to understand or locate any microchannels, but we couldn't make out due to multiple branches. Yeah, we took a fielder XTR to explore any microchannels, but this is where fielder XTR stuck, and the guide is also not much supportive. So for further advancement of fielder XTR or further wire escalation, which definitely needs a good guide support. So this is the first hostility I had in this case. So that's when we ended up in retrograde. So we took this septal channel, which appeared to be connecting an RV branch. You can see here. So wire went CO03 just went into RV branch, and yeah, this is the second hostility I had, because RV branch is hypermobile, and and you can see the bend in RV branch. This is a kind of bend. So when such bend is there, advancing microcatheter can injure collateral here. So septal to RV branch collateral, so septal to epicardial transition is more vulnerable for rupture when you try an advanced microcatheter here. So that's where I walked out of RV branch collateral and explored further first septal collateral. And again we had a problem here, so despite repeated attempts, I couldn't enter into the first septal. That's the reason I had to take a crusade catheter to enter into first septal, and then we balloon dilated. So this is the third hostility I had during the procedure. And after we entered first septal, we visualized course of the vessel, and then CO03 crossed into PDA and then into RCA. Now you can see here again RCA, mid RCA is showing a huge bend. So you can see here, this is the mid RCA, almost like a sinusoidal bend in the mid RCA. You can see in our view. So, and microcatheter is stuck here, so it's not advancing. I think the next hostility I had, because of this non-advancement of microcatheter, so we decided to go ahead with a marker wire technique, and I escalated and advanced antegrade wire, that is Gaia 2, into using retrograde wire as a marker, but couldn't succeed again because of the loops sitting inside the vessel. So the next hostility I had, and then again, so I had to upgrade my retrograde wire to Pilot 200 because this is a wire which can really take loops of the vessel, unlike Gaia 2, Gaia 3 or other stiff wires. So Pilot went into proximal vessel, but again here it went subintimal, and so we couldn't bring back into the antegrade guide. So yeah, this is a next hostility I had. So at this stage we decided to take a change microcatheter to Caravel and advance microcatheter up to the distal cap, then only we get support to retrograde wire escalation. So that's what we did, changed retrograde microcatheter to Caravel, and Caravel went up to distal cap, and then we took a Gaia 2 wire, escalated to Gaia 2, so to further advance into the guide. You can see here in the process I lost my antegrade wire, which was into RCA as well as the microcatheter, so I had to advance Gaia 2 into JR after amplurgerization of JR. You can see here, so I'm advancing Gaia 2 into the amplurgerized JR, so it just entered JR. But what happened is, after balloon trapping of retrograde wire in antegrade guide, we tried advancing Caravel, but Caravel stuck here, and when we tried further, we exchanged Caravel to Corsair. In the process, the retrograde wire looped in the aorta. So this is the next hostility I had. At this stage I had to change antegrade guide to again amplurger AL 0.75, and we took a snare and snared retrograde wire in aorta again. So yeah, we can see here we snared retrograde wire, that's a Gaia 2, and pull it into the antegrade guide. Then we externalized. After externalization, so we dilated with 1 mm and 2 mm balloons, and you can see here the vessel is not visible, mainly because of the concertina. And yeah, we can see there is a dissection also here. We did IVUS. You can see this is the distal vessel, and you can see there is a dissection at the ostium, and so dissection at the ostium, and the ostium is clean. So we created a small false lumen at this area, and we wanted to exactly land at the ostium. So we sized according to IVUS, and then we stunted with a 338 mm stent. But you can see post stunting, this is the proximal edge of the stent. Yeah, beyond the stent there is a block, and there is also a lumen. This is a true lumen which is compressed. So yeah, we missed proximal landing zone. So this is the next hostility I had, and then I took another 3.5 18 mm stent and deployed, and later we removed retrograde wire with a kissing microcatheter technique. You can see here 2 microcatheters are close by, and then we can retrieve RG wire without any injury to the tissues. And after RG wire removal, we checked the septal angiogram. So there is no issue except some issue here, and then we injected through microcatheter from RCA. Then we made out there is a mild septal injury with septal hematoma. So this is the next hostility I had, and yeah, so we waited for 5 minutes and rechecked. It is non-expansile septal hematoma, so that's when we thought we can leave it. And then we came back to our retrograde care and stunt in LED, and we re-optimized stunt in LED using IVUS with 3 and 3.5 balloons. And this is a final right coronary artery result which you can appreciate. So this is a final result. So patent RV branch and good stunt expansion till ostium, and there is only a small septal hematoma. So this is a final IVUS. You can see here, so this is the distal reference, and this is a stunt area in the distal stunt, and this is the proximal stunt area at the ostium, which is almost 9.5. So we had good stunt areas all across. So this case clearly says, so CTO is persistence of operator is very important in a CTO intervention. So at every step we had a problem, and we circumvent problems with various techniques, and finally we could complete the case. Thank you. You can subscribe to our channel, so through which we upload all our complex cases.